I'm Alexis Del Cid, and I hope you're all having a wonderful start to 2026. Our team is taking this month to gather phenomenal news stories and topics for our next season of All Things Heart, beginning the first Thursday of February. And we already have some great patients lined up for you, like this Alaska man, Bart Rudolph, who chose to fly from Alaska to the University of Kansas Health System for his open heart surgery because there was no place he trusted more. And then Ryan Azuz, a young man living with an incurable disease who's joined his second clinical trial to help find a cure that could help others in the future. We are excited for what's to come. Until then, please enjoy this Encore presentation. She had a pacemaker, then she needed a double mastectomy. The solution? Replacing it with the tiniest pacemaker in the world. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. October is Breast Cancer Awareness Month, and breast cancer affects 1 in 8 women in America. 1 in 8. Abby Ravel's journey, though, begins with her heart.
So there's a photo of me ziplining at the top of Europe. I had never ziplined before, so it was one of those bucket list items.
Having just returned from the trip of a lifetime with her daughter and husband, Abby Ravel is on cloud 9.
Every day we walked so many miles. At the end of our 16-day European vacation, we ended up walking 96 miles. We did go to the Paris catacombs.
It's an experience she once doubted would ever be possible.
About 200 stairs down and 200 stairs back up.
Abby's medical journey actually began 12 years ago at the age of 29 when she was having lunch with some coworkers.
We were at a restaurant downtown and I fainted at lunch.
Her general practitioner referred her to a cardiologist for some testing.
And during that, I had an 8-second asystole pause.
What's that?
Where my heart flatlined.
She was diagnosed with something called neurocardiogenic syncope, meaning her body's nervous system was malfunctioning, causing sudden drops in blood pressure and bouts of slower heart rates, causing her to pass out. She was referred to the University of Kansas Health System electrophysiologist Rhea Pimentel for a pacemaker.
Dr. Pimentel really made me feel comfortable, and it was nice that she was young and she obviously knew what she was talking about, and she's very talented and she came highly recommended from everybody.
For the next decade, Abby's life went back to normal until 2023. That's when her OBGYN recommended genetic testing because of a family history of breast and ovarian cancers. The test revealed that Abby carried the BRCA gene, and she knew she had some very big choices to make.
This is telling me I have an 87% chance of getting hereditary breast cancer or ovarian cancer. So if I have an 87% chance that a plane is going to crash, if I stepped onto it, would I get on the plane?
4 months later, Abby had a hysterectomy. Next, she scheduled a double mastectomy and reconstructive surgeries. But those surgeries on her breasts would be complicated by the pacemaker already implanted in Abby's chest.
One of the big concerns with the placement of the pacemaker is you cannot get clean margins when you're doing the mastectomy.
Her oncology, cardiology, and surgical teams all met together to come up with a treatment plan. First, they'd remove the pacemaker. Next, they'd perform the mastectomy and reconstructive surgeries, and then replace the old pacemaker with this, the tiniest pacemaker in existence. It's about the size of a pinky fingertip. It's also leadless, meaning there are no wires, which doctors say makes this kind of pacemaker a great option post-mastectomy. Even better, it was installed through Abby's femoral vein. No more cutting and no residual lumps or bumps in the chest. And once Abby was on the other side of the most grueling year she's ever endured,
I felt the huge sense of relief. After the surgery, you think that you will never be the same. It feels so cumbersome, but a year later, and I was back to normal, and that was, a miracle in itself.
We are so pleased to have Abby joining us today. Thank you for being here.
Thank you.
We're so honored that you're willing to share your journey. And we also have her electrophysiologist, Dr. Rhea Pimentel. Thank you for taking time. And her breast surgical oncologist, Dr. Kelsey Larson, who's been doing the surgeries on Abby. Thank you all. How are you feeling today?
I'm feeling pretty good. I just had part 4 of my reconstructive journey a couple weeks ago, so I'm feeling great.
And this one, they took some tissue out of your arm?
They did, tissue out of my arm and my thighs for the reconstructive process.
That is very typical to have more than one surgery in the reconstruction process, right?
Yeah, absolutely. Even for very young and very healthy people like her, the reconstruction is not a one and done process. And so just like she shared, this has been a journey, so too is the mastectomy and the reconstruction journey.
When it came to the first pacemaker, Abby got her first pacemaker at 29. Is that considered young?
Yes, that is considered young. Although I will say that as over the last probably 10, 20 years, we've started to see more and more patients become candidates for pacemakers. And in Abby's case, it was really necessary. I mean, and you can speak to this, but it was really ruining your quality of life more than anything else. Yeah. And while we don't typically say, oh, you need a pacemaker as a first-line treatment for someone as young as her, it was pretty clear that we didn't have any other options.
Are you seeing more young people become candidates for it because more young people are having heart problems, or technology has made it possible to give more young people these devices?
I think technology is making it more useful, and in addition, we're understanding more about how the heart works in general and how certain symptoms cause certain physiologic changes that we can fix with devices.
Is there any concern putting something that's a long-term device in someone that's so young?
Oh, there's a lot of concerns. There's a lot of concerns because obviously these, her initial device had leads that were placed through her veins into her heart. And, those leads don't last forever. If you can imagine, the heart is squeezing with every single heartbeat on that lead. So after 10, 15, 20 years, the younger the patient is, the less long it lasts. Because of all the activity a younger patient does, the leads will fail. And then we have to make a tough decision about removing leads and then putting a new set of leads in, or do they even need the pacemaker anymore, or so forth. And Abby's gone through a few of these extractions, one where the lead actually broke.
Right.
Yep. So it's not a one and done thing.
No, it is not.
You were cruising along for 10 years thinking that was your only problem.
Correct.
Then you test positive for the BRCA gene.
Correct.
Dr. Larson, she learned that she carries the BRCA1 gene. What's the difference between BRCA1 and BRCA2?
Yeah, great question. So both from a breast cancer standpoint make a woman at elevated risk for breast cancer. There are other cancers that can be associated with both genes, but a little bit different ratios of the different types of cancer. Things like ovarian cancer, pancreatic cancer, melanomas, those type of things. But both are passed down through families most commonly.
And that was my next question. Do you know if anyone else in your family has tested positive for this?
So far, I'm not aware of anyone else who has tested positive. My sister is the only one who's actually tested, and she has been negative. My mother is almost mid-70s, and so she just did not want to test, and then my father has passed. So,
but it's always genetic?
Most often it's genetic. There are occasions when they can be sporadic or spontaneous, but most often it's genetic. So patients like her, you had a family member with ovarian cancer.
Correct.
Her doctor, her GYN did a great job of flagging that and talking to you about that. That is one of the things, family history of ovarian cancer, pancreatic cancer, multiple relatives with breast cancer. Those would be people who might want to explore genetic testing.
Right.
And hats off to your family doctor who recommended you get tested.
Absolutely.
Yes.
Was that anything that was in your mind before that visit, that you would need to get tested for that?
No, it was something that she had started a couple years before. There was like a questionnaire every time you showed up. She would ask, are there any new cancers that have shown up in your family? And that was the first time that I had to flag, ovarian cancer. I had a couple of breast cancers. I didn't even think of a cousin that had passed away from pancreatic cancer when he was 40. So I, started to really think about it. And then my aunt had passed away from ovarian cancer. So I flagged that, and she's like, okay, I think it might be time to go ahead and get the genetic testing done. I didn't really think anything of it. She was like, if insurance pays for it, great. If it doesn't, we'll call you and you can decide if you want to send it in and do it anyway, or there might be some payment plans we could do to get this testing done, but it was covered under insurance.
Great.
And yeah, it definitely was a shock when I got the call.
I can't even imagine how stunning that is, because you're still a young woman finding this
Correct.
out. And you had to make, do we have any tissues back here?
Oh, no,
I might have
you're
to
good.
call Anthony to bring us some tissues. We get emotional during these shows. He's on his way. He's on his way with box tissues, because I might cry too talking to you.
Okay.
You made this incredibly bold decision to have both your breasts removed.
Correct.
Double mastectomy.
Yep.
And the way you put it in our interview, I've never heard it put like that before, that if you had an 87% chance of stepping on a plane and something bad happening, you wouldn't get on that plane.
Correct. Yeah.
And those were your chances of getting cancer.
Correct. Yeah.
At what point during this decision did you learn that your pacemaker in you with all these cords on it was going to be an issue?
I think it was when I was talking with Dr. Larson, actually during one of my first consults. She said, I really advise this, mastectomy, and she said, but with your placement of your pacemaker, I cannot really get clean margins around the pacemaker. So it kind of negates the need for a mastectomy.
Right.
Because while it would lower the chances, it wouldn't take it away. So then it was like, why go through all of that when it was, kind of like halfway done? So,
Right, you needed clean margins.
Correct.
So then, Dr. Pimentel, when it comes to the pacemaker, and Anthony, thank you for the tissues. I might need those too as we keep talking. When it comes to the pacemaker, this is the tiniest pacemaker in the world with no cords. You brought in some examples, and
I did.
we can get a great shot of this on our camera.
So when we first put the pacemaker in Abby, we had one of these devices.
Okay, let's hold this one up. So this is the first one. Where should I hold it? Robin, hold it in front of your shirt because it's blue with the better background. There we go. So it had this, and then where are the cords?
So this is as we call it, the leads that we talked about, and they fit into the little holes here. And then the very tips go in the heart muscle itself. So in Abby's case, she had one in the top chamber of her heart and one in the bottom chamber of your heart. And you can imagine over time, scar tissue will develop around these blood vessels, making it a little bit harder to take out. But this was her initial device, and really still 90% of devices that we put in these days. When we went back in an effort to keep everything out of her chest wall, we ended up putting what we call a leadless pacemaker.
Wow, it's so tiny.
Which I don't know how to show you this, but you can see that this end, if you get a close-up of it, has a little
hole in it.
little corkscrew in it, and that's how we end up doing our affixing it to the heart muscle.
Okay, there's
is
a
we
little
screw it in,
a little screw thing,
kind of like a
here.
little corkscrew in. So we put, in Abby's case initially, when we took the entire device, her old device out, we put one of these in the bottom chamber of the heart because it wasn't yet approved to put one in the top chamber of the heart. So
Approved by
multiple levels, approved by insurance, approved by the hospital, initially approved by FDA, although I think by the time we decided it was already FDA approved.
Correct.
It just hadn't moved through the insurance cycle. So while the bottom chamber leadless one is was approved at the time, the top was not. So,
okay, so I saw in the image there were two in her
Yes.
heart. Okay, let's
Yes.
talk about that, because that's what I want to ask you about with this question of what kept her heart beating correctly during the wait.
Yeah.
Was it the little, they look like,
the bottom one, so the one
bottom,
pointing
okay.
down is the one to the bottom chamber of the heart, which was already approved by insurance.
okay.
And so that was functioning more, I would say, a backup. So it really wasn't on all the time. It was only just to prevent something catastrophic from happening. If she had another one of those 6-second, 8-second pauses, it would kick in and pace her heart. But really what we needed is something to pace her heart, sort of like her own heart beats on a daily basis. And that's what the top chamber one does, the one that is sort of angling upwards.
This is such a good example of how all of our specialists are collaborating together on the same patient.
Yeah.
All the time. How often, Dr. Larson, are you consulting and working as a team with electrophysiologists and cardiologists and other specialists?
Yeah. So the devices, any sort of cardiac device, whether it's a pacer, defibrillator, or whatever it is, The device that she was showing, the little gold part there, it sits in the anterior part of the chest. So it sits on the front of the chest.
You're talking about this?
Yeah.
The old one?
Yeah.
Okay.
And so any patient who has breast tissue, of course, that would be in the area of the breast tissue, right? So most of the time, it's not a problem. We can still safely do breast cancer screening. People can get mammograms and ultrasounds and biopsies and all those things. In the cases where we have to do mastectomy, just anatomically, it is in the anatomic boundaries that we need to go to get the breast tissue removed for a mastectomy. Every now and again, it is close, or it happens to be close, to where we need to do a lumpectomy. And so we do partner with our friends in cardiology, cardiac surgery, EP, often, because we do have patients who have these things in, maybe not as young as you are for these reasons, but who are older patients who have them, and they need these type of things adjusted and worked on with both teams in order to have safe cancer treatment and appropriate cancer treatment as well.
Abby, was she the first one ever to get this pacemaker?
She was not the first one ever. She was the first one at this institution.
She was the first one at the health system.
That's correct. Yes, yes, and the first one that I did for the top chamber. But yeah, there was much rejoicing.
Of course.
when we were able to put it in.
What does rejoicing look like when you're in the surgery room? Are you erupting in cheers? Are you high-fiving?
It was cheers when we were able to actually schedule it. That was
Yes.
probably the pretty, because you
bet.
had waited like a year.
It was about a year.
It was a long time.
How nerve-wracking.
Yeah, it definitely was. And I know at one point talked about taking out the one that we put in and putting back in a traditional pacemaker, just because I felt not very well for that year while I waited. But we held out, and
We held out.
it got approved.
We called. We made many phone calls.
You fought for her.
Yeah.
You all fought for her, and you have so much to live for.
Yeah.
You
I
brought your
appreciate
daughter
it.
and your son with you today. They're in the control room watching, or your daughter and your husband.
Yeah. I was like, wow, I didn't know I had a son. Yeah.
Daughter and your husband. Sorry, Hubs. So we love getting our viewer questions and comments. And if you have something that you'd like us to read out loud on the program, you can send it to us right now on Facebook or the All Things Heart email. You can see all the links on how you can connect with us in real time right there on your screen. So, Abby, now that you've had both pacemakers, can you feel a difference?
Well, I can feel a difference physically that, I don't feel the leads, I don't feel the pacemaker on my body. The actual functioning of the pacemaker, I don't feel a difference at all.
So before you could actually feel the pacemaker below your skin?
Oh, yes.
And feel the cords?
Yeah, and the thinner skin on your chest, or the thinner you are, the thinner the patient, the more it sticks out, the more the leads stick out. Specifically, when Dr. Pimentel put in my pacemaker originally and put it in my left breast tissue, she had longer leads, and so they had to kind of curl up, and so they were, sticking out on my arm. So if I wore a sleeveless shirt, you could kind of see the leads sticking out of my skin there.
Yeah.
But of course, now with the leadless, there's
It's just
nothing. Yeah.
in there. That's brilliant.
Yeah.
What did you think when you heard this was an option and that you would be the first?
I was just relieved. Really, I was just relieved that I was able to proceed with my prophylactic surgeries and to get the pacemaker done. Beyond that, I really don't know. I was kind of just in a state of shock when all of this was going on. But
Like a 1-year state of being stunned.
yes,
And just
absolutely.
walking through it.
Yep.
Dr. Pimentel, do you ever put this tiny little pacemaker in patients who haven't had double mastectomies? Is that an option?
Yes. Yeah. It's a great option, particularly for patients who have limited access up in their chest wall, either because they've had previous breast cancer and lymph node dissection, or if they're dialysis patients, or if they have ports in, we can't use one side. Also, patients who really only need one of their 2 chambers paced. Abby has a lead in each chamber, again, mostly because we were waiting for the top chamber one, but she could have, if everything was approved on the day that we decided to do this, she could have gotten away with just one lead.
What's the lifespan of the tiny one?
So the bottom chamber lead, which is the initial one you got, has a lifespan of up to 20 years.
Oh, wow.
The top one is 15.
Okay, that's
so
better than the
it's better than
before.
the old school kind. So,
sure,
yeah.
last longer.
Yeah.
You had so much going on. This is, a lot of people would have trouble wrapping their head around getting a pacemaker.
Right.
And you've had go through pacemaker, double mastectomy, new pacemaker. That's
Correct.
a lot.
Correct.
As a young mom.
Yep.
Dr. Larson, were you hesitant to perform a double mastectomy knowing that Abby had all this going on?
It's not so much about having the things going on. It's more so about, can we get you safely and healthily through the surgery.
Right.
So there are patients whose hearts are in a way where they are not safe to have this type of a surgery, right? We wouldn't put someone's heart at immediate risk for a larger surgery that they may or may not really need. But in her case, just the fact that she's very proactive about her health, the fact that she's very engaged with her team and with her doctors, it's very easy for someone who is like that for us to try to work through the situations and come up with a solution that addresses both concerns for her.
And do it safely. After a double mastectomy and a hysterectomy, is there still a risk of cancer, or does that remove it?
Yeah, great question. A lot of people think after mastectomy that there's zero risk of cancer. That's not actually true. So we can reduce someone's risk to breast cancer perhaps as low as 5% in their lifetime. So compared to starting above 80%, that's a pretty good risk reduction and a pretty good benefit.
Yep.
Reminder that the average woman's risk of breast cancer is somewhere around 12-13%. So she's actually at a fraction of the average woman's risk of cancer because of the surgery.
We've got some great community questions coming in, so I want to get to those. Jeremy has a question about the leadless pacemaker. He wants to know, does the leadless pacemaker reduce the possibility of infections since you're not needing to go back in and replace the old leads?
Yes, yes. So you're not changing the battery out as frequently, so that decreases your risk. If you think about it just from the standpoint of it's a smaller device, so there's less chance of bacteria hitting that lead, so your infection risk is decreased that way. And because it's partially in the heart has a way, the body has a way of putting skin on top of it, and we call it endothelialization, which also protects it from infection.
Marie wants to know, is a pacemaker with leads ever a better option for someone?
Yes, yes. In some patients who require pacing all the time, and who require a special type of pacing from a specific area in the heart. This technology, while it's excellent for providing pacing, doesn't do as many of the bells and whistles that our traditional devices do. And so, you know, as we have all said, Abby is otherwise very, very healthy, and so she just kind of needed something to keep her heart going at a certain heart rate. But some patients need more, and those patients would get a transvenous device.
Laura has a question about emotional support for you, Abby.
Okay.
You've been through so much, and so
Correct.
Laura wrote in and wanted to know if the emotional support helped you with your physical recovery.
Oh, absolutely. Just having my family around me, my husband, my daughter, my extended family, everybody helped. So it was great. Yeah.
Let's get her those tissues.
It's all right.
It's okay. You know, it's good. It's good to have that emotional support. I've heard doctors say, Dr. Larson, that the patients who have a broader system of support in place actually physically do better.
Well, I think that's absolutely true, right? When anyone is feeling vulnerable because they're having healthcare things going on, why wouldn't you want support around, right? Why wouldn't you want friends and family, and who wouldn't want that in their lives? Who wouldn't want those relationships to help them through it and to keep them going? And like you said, it was a hard year for you, but those people were the ones who kind of kept you going day in and day out. You saw us sometimes, but they were there with you all the time. So.
Yep.
I love seeing the pictures of you ziplining
Oh,
through
yeah.
Europe and walking 96 miles, which is something
That was crazy.
one time you thought you could never do.
Right.
Joan has a question about insurance. Is it more expensive insurance-wise to do leadless than the one with the cords?
Yes, and primarily because of all the other equipment that's necessary. So we deliver the device through the groin, which can be a little bit painful because it's such a large delivery tool. So we oftentimes will use a lot more anesthesia, which increases costs. So that also is an issue. And then keep in mind, she has 2 leads in there. Those are 2 separate pacemakers.
Oh, the
So
two little, they look like
each
little
lead is a
little
pacemaker.
bullets. Okay.
The two bullets are each pacemaker. So she technically has 2 pacemakers in her body.
Okay.
So-
2 teeny tiny
Correct.
ones.
It's almost as if you got 2 of these transvenous
Oh,
devices.
okay. Okay, so it's more expensive that way. When you put the pacemaker in her through her
Groin.
femoral vein, yeah. Is Abby awake in a twilight, or is she completely out?
She's out.
She's out.
She's like, I want to be out.
This isn't something that
No.
So you're out. And then when you woke up, did you feel instant pain in your leg or pain in your chest? What did it feel like when you came to?
Well, so my very first one, definitely your leg, and I think I was required to lay flat for like 6 or 8 hours.
Oh, man.
And they put a stitch, and they have to hold pressure for 30 minutes or something.
Yeah.
So, I mean, you wake up kind of groggy out of anesthesia and somebody's leaning on you, like their full body pressure, holding pressure. And then you lay flat. And then I unfortunately had a complication, and I had a hematoma.
Oh, yeah. Remember that?
It went.
Explain to our audience what's a hematoma for people who are non-medical people.
So it's bleeding underneath. So just as a backup, the initial device that she had put in, we did it at the same time we took the old device out.
Right.
So as Abby's already mentioned, when we originally put the pacemaker in, I actually buried the generator in breast tissue, and breast tissue is very, it's well vascularized, so it bleeds. It has a tendency to bleed very much, and so when we pulled everything out, we didn't have any trouble putting the new leadless pacemaker in, but the site where we took all the old stuff out had a lot of bleeding. And bleeding, hematoma is bleeding underneath the skin.
Okay.
So you wouldn't see the blood coming out, but it would be very swollen and painful.
Puffed up.
And that I remember that now. That took a little while to resolve. I think I even called you and asked you what your opinion was. How could I make this better for this poor woman? So
That was my next question. Are you ever in the surgery room together?
It's not a great day for a cancer surgeon if we have to be in the cardiac ORs. So it's not that it could never happen, but also we have to remember what are our priorities, right? So heart always comes first. And so we want to make sure that she is safe and 100% from her heart standpoint. That includes things like the recovery area after that you were describing. And so they always take priority, and then we time whatever is safe from a cancer or a risk prevention standpoint based on what is safe from the heart.
Kim Bosley Moore wants to know if the leadless pacemaker has batteries that will need to be replaced.
that's a really good question. So currently, there's no way to replace that battery. Most of the old studies, and keep in mind this device has probably been around for about 10 years in Europe. So what they've been doing is they've been simply putting another pacemaker bullet next to the old one and then turning off the old one and just having a new one in there. There is a mechanism for you can unscrew it and take it out, but nobody likes to do that because after a while, like I said, it's kind of healed into the heart. So if you unscrew
All
it,
that tissue has gone around it.
Yeah, there's some risks to that. So
What did women used to do who needed double mastectomies before this was an option? I mean, this just became an option, so what would you do for women before that?
Well, remember, it's all about what are the relative risks of things, right? So we talk and we say, why does a person have the cardiac device, whatever that device is? Is this something that they really, really need to keep to live, right? And in that case, then what they do is they continue with their cardiac device and they continue with breast cancer screening. Because we know that breast cancer could come in a very small size, a very small area. Sometimes we can do smaller surgeries. So if we could do a little more of a surgery for risk reduction, we want to offer that. But ultimately, we wouldn't put someone's heart at immediate risk in order to do risk reduction because we can safely screen people. So it's nice this is available because now there's another option for people like you who might want that.
It's really amazing.
if it's just one side, one breast, we oftentimes will talk about moving it to the other side too. That's probably more likely with like radiation therapy and things like that.
Like you just move the cords over to the other
Either
side?
move the cords, either move the cords over or extract the entire thing and then reimplant it on the other side would be the other option.
What I'm hearing, taking away, is there's so many options for patients now, and there's hope for patients. They can get what they need and what they want with all this advanced technology. And with you as a team, you're an incredible team, and you're part of that care team.
Yeah, absolutely.
For today's takeaways, Abby, I want to start with you. What do you most want, not only our viewers to know, but your care team and your family that's watching this?
I just want to say thank you to everybody. I really appreciate it. Yeah, it was just, I'm just so happy to be on the other side of it. Yeah.
It's fun to hear you talking about your daughter going away to college, and
I
you
know.
get to see all these
I don't even want to talk about
milestones.
that yet. We still have a year.
Every parent starts crying when they talk about that.
Yeah, we still have a year. But yes, I'm looking forward to it, but not at the same time. I'm very proud of her.
Yeah. Dr. Larson, what about you? What do you want our viewers to know?
You know, I hope people heard over and over again how important it is for patients like you to be proactive. And that's really what I take away, I think, from a lot of this is she is a great person. She's a proactive person. She wants to do what she can for her health, and she certainly can't control these things that happen to her. It's not because she was doing anything, but because she is so proactive and so communicative, then she can have all the benefits and all the wonderful things going forward.
And Dr. Pimentel?
Well, I just want to reiterate what Dr. Larson said. It's always great to have a patient who is willing to do their part and be part of the plan and the treatment itself. I also think that communication is just always so key. I mean, she came to me, she said, I can't live this way. This is what I want. This is what I don't want. And fortunately, we were able to figure out a plan amongst all of us that would work to let her be where she is right now. And
Get back
so
to
happy
living.
about that.
Yeah. Thank you all for being here, and thank you for coming on and sharing your journey. And before we leave our audience, we do want to share a great moment from our Heart Center. It was an impromptu dance party for one of our patients. This is Christina. Christina got a heart transplant 2 months ago, and so she's been here recovering ever since, and Christina gets a little bored. So our team found out she loves music and dancing. They decided to bring the party to her.
When you have a series of bad days, I'm going to have a series of dance parties. We color with them. We do whatever they need us to do. That's the advocacy part of being a nurse, and that's part of our professional identity is being able to be the full caregiver. It's never just the patient, it's the patient, their family, and whatever they need.
We have the most amazing nurses here at the health system. That's cardiac nurse Ginger Ireland Hoffman. We love Ginger. We actually have her coming up on an episode in the future because she has her own heart journey. Our patient Christina is doing great today. And thank you so much for being with us today. If you'd like to watch or share any one of our previous episodes, just scan the QR code that's on your screen right now. It will take you to links of all of our past episodes.